And hello, everyone. Welcome to 2022. We're talking today about advancing molecular diagnostics in acute leukemia. This is my disclosure statement. I have done a number of consulting, as well as having current research funding from a number of private industry, which I will avoid and not talk about today. And so the overview for today, we're really going to concentrate on acute leukemias. First, starting with the core binding factor acute leukemia work that we have been doing over the last 5 to 6 years, then looking at the clinical trials work that we've been doing and gearing up for. And then finally ending with work that we've been doing in our laboratory for global oncology and the point of care diagnostics development. So starting with the core binding factor acute leukemias, these comprise about 12 to 15% of all acute myeloid leukemias. They are characterized by fusion genes with the core binding factor components, and they typically have an 821 translocation that's between RUNX1 and ITO, or inversion 16 and translocation 1616 that involves CBF-B. About 20 to 30% of these CBF-AMLs show a KIT mutation in exon 8 or exon 17, most commonly at codon 816. And on the left here, you see some images that we typically use and associate with these. So in version 16, typically we associate with myeloid sarcoma, although you can see that in 821s as well. In 821 leukemias, these typically present with large blasts showing maturation in your myeloid precursors. And in version 16, you typically see abnormal eosinophils with these patients. So the state of knowledge in 2015, this is before the 2016 WHO was published. At that time, the state of knowledge was that these were generally good prognosis and that we generally can lump inversion 16 to 821s because they were considered the same, and that you don't need to transplant patients who have achieved first complete remission. However, persistent questions at the time are, what if we can further stratify these patients? At that time, targeted treatments were becoming available, and what if we can further improve their prognosis? What was the impact of cooperating molecular mutations as NGS becomes more and more standard of care? And was there a poor prognosis group that could benefit from earlier transplant? So with that, an international core binding factor AML consortium, and now it's 13 centers and it's been 6 years and ongoing, got together, and you can see a number of institutions from the United States as well as internationally got together. And we formed a consortium of hematology oncologists, pathologists, as well as statisticians to really look retrospectively at patients with CBF-AML. 3 initial projects were identified. One looking at the impact of secondary cytogenetics and molecular mutations. This was spearheaded by our group here at UW and Fred Hutch. A second project looked at developing a risk scoring system. This was spearheaded by investigators at the University of Minnesota. And then finally, if there was a prediction for treatment failures, and this was spearheaded by the group at City of Hope. Our study design was that we were including everyone who had CBF-AML from our institutions. They were diagnosed between July 1996 and January 2017. January 2017 is kind of arbitrary. We kept collecting data until finally we all said, okay, we have to stop. We have to start analyzing data. And January 2017 was when we cut it off and said, we have to stop collecting data and start analyzing data and start writing. And so every patient had to have a diagnostic marrow sample that was available for pathology review. And there was central path review by the group of pathologists that's in the consortium. And then there was also clinical data that was available for every single one of these patients. And so that equal to about 537 patients. And about half of them had inversion 16, half of them had 821s. And you kind of see the data for karyotype, composite karyotype, secondary abnormalities, and subclone hairs, because this is a figure taken from the manuscript that I wrote. And we did do those types of analysis. But really, I want to get to the next slide, which really investigated whether or not inversion 16s and 821 are the same or different. And we can say now that they're definitely different. Inversion 16 tended to have increased trisomies 8, 21, and 22, and hypodiploidy were more common. In addition, trisomy 8s were associated with improved overall survival, whereas the others had decreased overall survival. Now, in contrast, 821 more frequently show deletion 9q, loss of sex chromosome, and hyperdiploidy. And specifically, hyperdiploidy and deletion 9q were associated with improved overall survival. An interesting observation was that overall survival was better for inversion 16, but disease-free survival was better for 821s. So this indicates possibly how we're treating these patients were also different. So why would that be the case? So next, we focused on specifically 821 AMLs to see if we can improve risk stratification. Within the 247 patients with 821 AML, about a quarter of them, 24.7%, received allogeneic transplant, and about 27% of these patients relapsed, despite having an initial CR of 92.7%. Now, the literature reports a slightly higher relapse rates. Now, most of the centers that were involved in this consortium are tertiary transplant centers, so that might explain why we had a little bit better relapse rate, but by and large, that's about right. And so what was resulting from this work was an ICB-FIT score based on age, white count, and the KIT 816 mutation and pseudodiploidy. So from this, you can actually give a patient a score. And when you're above 0, you're high. When you're below 0, you're low. And what does this mean for these patients? So this actually informs whether a patient may or may not benefit from allogeneic transplant. Now, these survival curves are based off of patients that had low score without transplant, low score with transplant, high score without transplant, and high score with transplant. And as you can see, these curves flip when you have low scores, whereas in both patients with high scores, you actually benefit. And so the result of this is that if you have an ICB-FIT score that is high, that patient may benefit from allogeneic transplant. The next study that our group had looked at was what predicts treatment failures in inversion 16. And not surprisingly, this boils down to age and white count. And the age cutoff was 43, white count was 98, and this is through the work of statisticians and Guido Marcucci down in City of Hope. As you can see here, for event-free survival, the poorest group was patients who were greater than 43 and had a very high white count above 98, whereas those with overall survival that fared the best were patients that were at or equal to 43 years of age and had a white count at or lower than 98. Now, how many of our patients actually had co-mutations, and what were the mutational data in our CBF-AML group? We know that fusion gene alone is not enough to cause leukemogenesis. And we also know that KIT mutations and other kinase mutations are associated with higher relapse rate. So this is molecular data from our cohort of 537 patients. Only 339 patients had mutation data. Our cohort went back to 1996. So this was, some of these patients were actually captured even before molecular testing was a thing, much less NGS. And so from our group of patients, about 11% in both inversion 16 and 821 groups actually had the 816 mutation, and a smaller percentage had KIT mutations that were outside of that 816 codon. And so that was 3% in inversion 16 and 5% in 821s. Overall, KIT mutation conferred poor prognosis, but in our analysis, really only fell out for 821 patients. And so, following this work on CBF-AML, I was really honored to be invited to be a responsible author for the CBF-AML chapters in the next WHO. And as part of this, we really did do a deep dive into MRD analysis and the significance in these patients. And so in the next couple of slides, we'll talk about a little bit about the WHO and some of the changes that are coming up in the WHO. So this is a proposed schematic of new subclassification. And as you can see, really at this next one, we're going to be defining by genetic abnormalities. We still have our categories where we are defining by differentiation and other things, but concentrating now on the AML with defining genetic abnormalities. And this is still a work in progress. But so a couple of the things that we can really look forward to change are that some of these are better defined. And also, in particular, the CBP alpha mutations, there's going to be some specific changes there, specifically dropping the biallelic and focusing more on the types of mutations that are significant for these patients. And then also a new chapter looking at other defined driver gene alterations in AML. And then the significance of blast counts are in hot discussion in WHO 2022. There's more emphasis on the clinical impact. The addition of clinicians as authors in most of the chapters has really changed how we think and how this information is going to be used. And also diseases are now classified on morphology, immunophenotype, genetics, molecular, and the clinical picture. There has been a call for improved blast enumeration with novel technology. And this is the image you see on the bottom is IMPRESS in leukemia. This is the work of Dr. Naresh Kakeri, Naresh, Suyan Chen, and Jonathan Fromm from our department. And so they really looked at and did a review paper on how blast counts are done and how it should be done in the next WHO. And so thank you for giving me the image and to talk about that. So really now, with the improved blast enumeration technologies, really we're looking at whether or not that 20% blast cutoff is needed in the future, especially when there is a clear recurrent molecular cytogenetic driver. And so in lots of the chapters, we're actually dropping that 20% blast cutoff. And coming back to MRD and CBF-AML, what we had discovered is that, or what we learned is that MRD is extremely important. This is measurable residual disease by a number of different ways. We've typically done this by fusion transcript, KIT mutation, or flow cytometry. From the MRC AML 15 study, this was done by fusion transcript on RT-PCR. And what they have shown is that, especially in this 3-course consolidation time point, you actually can predict relapse rate at a very, very precise way. And also rising MRD on serial monitoring is another way we can predict relapse risk. In 2 other related studies that centers around whether or not there's persistent and measurable residual disease with KIT mutation detection indicate a role for allogeneic transplant in these studies. And so this was conducted by 2 different groups. One is a Chinese study which compared chemotherapy to transplant, and the data for the survival curves is shown here to the left, and the paper is referenced down here. And there's a second study by MD Anderson that specifically looked at MRD at day 100 and whether or not that time point can help determine if there is a role for allogeneic transplant. And so what is our lab doing in terms of AML MRD detection? So we have 2 methods which we can detect MRD and AML. There's a digital platform by QIAcuity. This is a 5-color multiplex digital assay. And I'm showing a picture of David Wolfson, who's a research assistant in my laboratory. He really spearheaded the development of this assay along with Olga Salatora, but she's going to come up later in another study. But David really has done all of the work that you see on the bottom here, looking at the initial development and verification of this instrument, and looking at how little you can go and how sensitive you can be, and also the capability of hyperwelling. He's looked at expression assay as well as DNA mutation assays. And so those are in development. We have AML panel as one of our assays, but we also are looking at CLL and also expression assays in that as well. And duplex sequencing, I don't have to go into too much detail here. Our department knows this technology very well, spun out of Larry Loeb's lab. And this is where you do need more input, and 500 nanograms is the minimum input that is recommended. If you have as much as 1 microgram of DNA that can be put in, that would be pretty good, but really you begin getting a plateau effect around 2 micrograms. And the idea for duplex sequencing really is that bioinformatically you can clean up a lot of the sequencing errors and therefore achieve that very specific and precise limit of detection for what's needed in measurable residual disease. I'm going to stop talking about duplex sequencing there and move on. So the result on the CBF-AML work really is a bunch of new friends and collaborators, a number of manuscripts that has now been published, 2 WHO chapters. And then really what we've learned is that MRD testing in CBF-AML is going to be very important, and we need assays to be able to detect this. In version 16 is not the same as 821, so differentiating them would be important, and treating them differently or may actually be important. ICB fit scores can help risk stratify and identify patients who will benefit from allogeneic transplant, and also a prediction algorithm for in version 16 patients who may incur treatment failure is also available. I'm going to move on to the next segment now for clinical trials. And these are the development work that we've done in the Hutchinson labs. And this is our website and a little bit of advertisement there for us. But for Precision Medicine AML MDS Trial, there is a one that's coming into our lab probably in the next 6 months. We're hoping to activate. And this is based off of Genexus myeloid assay. This is an umbrella trial for AML and MDS patients that are enrolled at diagnosis, and there will be multiple sub-studies to look at current as well as investigational agents, as well as a number of novel combinations of these. Every patient who is going to be enrolled will have their blood genetically screened by NGS with a 3-day turnaround. Yeah, that's going to be challenging, but we can do it, and I'll show you the platform that we intend to do this with. They will be assigned into an initial sub-study. If the patients relapse or have significant toxicity, they will be moved into a different sub-study. And this also, along the way, has an algorithm to investigate the significance and treatment of measurable residual disease. The platform in question, I know our department is invested into Illumina, but a number of labs are using ion torrent next generation sequencing now. This is based on a hydrogen dissociation and a very sensitive pH meter. And with this, the advantage of this system is that it's an all-in-one box. Basically, these little chips go in here and you do all of your sequencing in there as well as your data analysis. Another advantage with the AmpliFix technology is that we're able to combine both the RNA as well as the DNA library preparation in the same library prep. And it's all happens inside the box. So in brief, this is the targets that the MyeloGenexus assay is capturing. So we have about 23 hotspot genes, 17 full genes sequenced, and as well as 29 fusion genes as we'll be going after. And there's our 5 expression genes with controls. And what this assay is designed to do is capture 93% of AML variants at about 3 that occurs at about 3%, and 72 variants that happens at about 1% in AML. On average, we expect our samples to give us about 1.5 to 2 million DNA reads and 300 to 500 RNA reads. And then on the bottom here, you see the projected timeline for a standard run, about 17 hours in total, 11 hours for library prep, 3 to 4 hours for templating, 1.5 hours for sequencing, and about 20 minutes for post-run. And then after that, we can actually go in and start data analysis at the same time that you start the next run. We've done a number of feasibility and harmonizing study. And so this work is actually done by, the physical labor is done by Lan Bepu, that's up on the left-hand side, and Pooja Sanduria on the right-hand side. We've have to harmonize with NCI Fredrick's lab, which is our sister lab for the clinical trial. And one of the harmonization is really just running a lot of samples and making sure that both our labs are getting the same thing, number 1. Number 2, that our SOPs are aligned. Number 3, that our QA, QC thresholding and parameters are also aligned. And so the blue dots and red dots indicate, Fred Hutch and Mocha runs. And basically a lot of these do overlap. So we're doing pretty good. And then one of the metrics we were looking at was low performing amplicons that had lower than 250x coverage. And we're also spot on that. And so just a very general, in the feasibility studies so far, we've run about 1,000 samples and 98% of those have passed. Great sensitivity, great specificity, and pretty good limit of detection, but we're keeping a very tight eye on that through the validation studies. Reproducibility has been very good, but we've done that only on about 154 libraries. And we have 100% concordance so far on the initial 8 blinded samples. We are going into our validation coming up because we also changed the chemistry from a V version 1 to a version 2 because of all of those low performing amplicons. We went back to the company and we said, hey, all these low performing amplicons, can you do something about it? And so they actually did listen and they went back and changed the chemistry. So we're waiting to start our validation on version 2. And then we also identified a potential problem coming up with FLT3 ITD. This is FLT3 internal tandem duplication, which can be anywhere from 3 base pairs up to about 300 plus base pairs. So we were worried with NGS short read sequencing that they weren't going to be able to capture some of the large reads. And what we ended up finding out is that this platform really cannot identify ITDs that were above 117 base pairs. It's probably around 120, but we didn't have any samples that was exactly 120. And so really it's about a 117 base pairs. And it also had challenges identifying all of the peaks that are seen in multiple peak ITDs. And so ultimately what that equals to is we're going to be missing about 8% of FLT3 ITDs if we did NGS alone. And so the clinical trial team now is deciding whether or not they need reflex PCR on that. So other molecular clinical trials that we're working on right now is the active ones that are ongoing include S1905. This is looking at an OBI 3424 prodrug, and the prodrug is down here. This is like a pretty important trial for patients who have relapsed refractory T-ALL. This is a very rare cancer happening in a very small percentage of patients, but this is really good because now they have an option for treatment. The other 3 active trials are all targeting patients with CML, and we're doing combinations with TKI therapy with a number of other things. Another upcoming and pending trial is looking at in S2111. This is a combination trial with Glastigib, which is a hedgehog inhibitor, with anti-CD22 for BALLs. And then the other trials, I'm not going to go into detail at this point. And so the last section that I want to talk about today has to do with global oncology and point of care and what we are doing there. So we're going to now, let's see if I can start a video. We're flying to Kampala. And so this is UCI, Fred Hutch Cancer Center in Kampala. What you see up here on this corner here, this is the central lab. And this is the Uganda Cancer Institute, which is next door. And this is Makerere University, which I had the privilege of visiting their residency program and pathology group. This was, they're about a block down from where the Hutch Cancer Center is, and the UCI is right next door. Let's see here. So what is the crux of a problem in low and middle income countries? Premature mortality is very high there. While cancer causes about 20% of deaths worldwide, approximately 70% of these cancer deaths occur in low and middle income countries. So that's a disproportion. And not surprisingly, this has to do with the lack of clinical oncology workforce. So that's right here, the deficit, and here is the cancer deaths. And then the other thing that has been identified is that earlier diagnosis is associated with earlier stage disease. We're a group of pathologists here, so I don't need to belabor this point. However, data does show that there's a lack of pathology services, including IHC, molecular, and cytogenetics that result in delay, incomplete, and inappropriate diagnoses in many of the low and middle income countries. In fact, 25% of the low income countries actually reported having accessible pathology services. So this is a Spot on CML. This is started by my mentor, Jerry Radich, who worked with the Max Foundation in identifying patients with CML. And Max Foundation got Novartis to provide drugs to patients that we were able to identify with CML. And this has been very successful. So far, 23 countries are involved, and almost the samples received, this was in December. So we've actually got a bolus of another bunch of samples that came in. So we're almost at 900 samples now, or maybe a little bit over, in helping patients identify patients with BCR-ABL from dry blood spots for CML. And what this equates to is that for this program is called the GLEVAC International Patient Assistance Program. And what this has shown is that the 5-year survival of patients who are on this program is the same as patients in high income countries. So I would call this a success. Now we asked, what else can we do? And so these are the people. We see Lon again, and this is Olga right here in the middle, and this is Jordan. And so basically, you know, the blood gets spotted on these cards and they get snail mailed over here. and we extract RNA and DNA from these filter paper cards, and we can do a number of things at this point. We started the program off with Cepheid BCR-ABL, but since then we've really pushed the envelope. We started doing RT-PCR with them, and we could do that. We've successfully done PCR for specific other targets. We did that as well. And then most recently in the last 2 years, we've actually challenged the system by doing fusion-plex and variant-plex sequencing and GS sequencing. And then most recently, in the last couple of months, we started doing the myeloid genetics assay on these cards, and that's been successful. And this is an example case here, which I'm going to blow up for you to show you what one of the reports here. This is a patient that has the BCR-ABL fusion, which we detected by RNA, and then we have the ABL1 T315I TKI resistance mutations here. And then this patient also has an AXSL1 indicating progression. And so now I want to take a pivot and talk about lymphoma tumor boards and how we're contributing to the lymphoma tumor boards. So lymphoma tumor boards has been around for over 10 years. It didn't start in 2017, but I got involved in 2017. And at that time, lymphoma tumor boards was at 2 to 3 a.m. And I say minimal pathology because I couldn't stay awake at 2 to 3 a.m. I tried, but it was extremely difficult to stay awake. And so for the times when they can actually wake me up and keep me up, I could help a little bit. In 2018, we started seeing path pictures being incorporated by the fellows in some of their presentations. That was amazing. And then in 2018, 2019, Andrea Tollerton, who's in Hootie's lab, she was on a mission to update and stabilize the internet, because that was the other challenge the Lymphoma Tumor Board was having, was that the internet kept falling. And sometimes the Lymphoma Tumor Board had to be canceled because of that. In 2019, I was able to do my site visit and do a lecture series for our fellows out in the HCRI, and really able to teach a lot of the pathology that is critical. And from then, they really made an effort to get pathology slides scanned in every week for lymphoma tumor boards. The initial system was an Apereo scan that then transferred to an Amazon cloud that went to London, which then transferred to Seattle. And it takes about 2 days, in short. And then it was shown on these image scopes, and oftentimes my computer would crash. But we got it done. It was amazing. It was very nice to show real-time path slides at lymphoma tumor boards. In 2020, we actually incorporated some molecular testing. This was a little bit challenging because how do you deliver molecular results at that time on dry blood spots, which is not validated? And so I felt really uneasy about that and decided we really need to do more teaching rather than delivering of results. And so it was more a lymphoma teaching molecular board for this and what these results may mean, and then also teaching about the assay. And so that translated to actually a clinical trial that is now ongoing at Uganda for molecular testing and helping them set up their own NGS. And in 2021, Liz Donato joined our group from Peggy's group, and she helped set up this semi-automated cloud-based LTB interface. And now these slides can actually come over and automatically be uploaded into the Halo Link software. And you can see an example down here where not only can I put up the H&E, but I can actually put up a couple of the IHC slides adjacent to it and be able to compare the IHC images together. And so in a nutshell, you don't have to read the 13 patients that we've helped so far on molecular tumor boards, but really this resulted in 8 patients where we discuss what potential findings could mean to their therapy. There's 2 patients that we raised a suggestion of maybe that CML is not the right diagnosis and you need to look at something else. Unfortunately, one of the patients died before molecular results could even be presented. And we hope that we can do better in the future, especially with on-site NGS testing. And with the last couple minutes here, I want to talk about the rapid point of care assay for heme malignancy. So the 2 diseases that we really try to target is, not surprisingly, CML. We have the most experience with that, and it's characterized by a nice fusion gene, BCR-ABL. And these patients we know have almost a near normal lifespan compared to patients in high-income countries if we can identify them and treat them with TKI therapy. For acute promyelocytic leukemias, these account for about 5 to 8% of AMLs. They're also characterized by a fusion gene, PML-RARA. And for these patients, if they present, they typically are in medical emergency with a risk of early death. And so identifying these patients and getting them into ATRA and arsenic would be really important in changing their life expectancy. And so the point of care based assays that we try to develop are based on isothermal PCR. These are basically methods that do not require Taq DNA polymerase for thermal cycling. And the types of alternative enzymes that we looked at include recombinase polymerase amplification, helicase dependent amplification, and LAMP, loop mediated isothermal amplification. The LAMP assay we developed ended up operating at 65 degrees and required 30 minutes to work. And so we kind of said, you know what, we don't really need, we don't want an assay that requires 65 degrees in incubation. We really wanted something closer to room temperature or body temperature. And so, yeah, this is just a cartoon picture of my wish list, if in the perfect world. And so finally, you know, we decided fusion testing by RPA would probably be our best bet, because we were able to get reactions for CML and APL down to 30 degrees and in about 10 to 15 minutes in an initial kind of iteration of this assay. This is looking at a number of patients and also a dilution cell line for APL specifically. And in the next slide, I'll also show you some more data on CML. So some things that we really thought about when we developed the assay was that we have to be able to lyophilize the reagents, because if we are targeting this for a global audience and we want this to be shelf stable, we want the lyophilized reagents to be able to target multiple different isoforms. We need the lyophilized reagents to contain all of the binding proteins and polymerases and stuff like that that it needs, and really shouldn't need anything special or fancy to initiate the reaction. So really you just need magnesium acetate to start the reaction in a vial. And then so the reaction does not require any equipment or electricity, and it happens for about 15 minutes. 30 degrees is a little bit challenging, but you might have to put it on your body or something like that, or have the patient hold it. And then finally, the last part for visualization is after the reaction happens, putting it on one of these little strips to basically see if it's positive or negative, and with a control line here. So for our initial patient and feasibility testing, we tested on some cell lines as well as patient samples. Reaction volume was 100 nanograms. Our limit of detection was down to 1 nanogram for the NB4 cell lines. And then also we were able to do the temperature gradient down to 30 degrees here. And so we did go further. What if we bumped up the input? So 5 nanograms up to 500 nanograms. So we played around with the LOD a little bit. And so this still needs a little further optimization, but this is our initial data. It was pretty sensitive and specific. It's pretty good at detecting, but a lot of input here. And then so the other thing we kind of pivoted and looked at was, well, can we do better point of care sequencing? So single molecule long read sequencing was developed in our lab by Olga Salatora here, and then Shashir Reddy, who joined our lab a couple of years ago, and he is a programmer. He's a computer scientist, and Olga is a hematologist. And so what they did was really look at nanopore sequencing and combining that with CRISPR chemistry. So why do we want to do this? Nanopore sequencing is pretty fast, 50 to 250 bases per second per pore. We can do ultra long reads. Right now we're averaging about 100 kb. Our longest read is 220 kbs. We can detect clonal heterogeneity, possibly clonal evolution with diffusion variants. This is if we do not amplify and we're using these single molecules by capture. So why do we think this is advantageous? We can overcome some of the short read challenges of NGS. We can actually detect epigenetics and DNA base pair modification through the nanopore squiggle signals. We can actually detect phase status of these mutations, CNV, as well as large indels in the same long read. There's really no amplification, so you're looking at the single molecule. There's multiple human genes that we can target. Right now we have not reached the theoretical 100 guide limit yet, but we're going to try. You're limited by viscosity of the final reagent. So we think we can go above 100. And then the enrichment we've been getting has been over 100x without the PCR amplification. And of course, a large region of interest. And you do need a lot of input to really be able to enrich for that region. And then if we can actually convert this to using the Flongo, which is another version of this nanopore, it's actually cheaper. And there are 4 other companies now that are coming up with different nanopore devices. So there are multiple nanopore companies out there. The limitations are, of course, as we all know, increased errors, but there are other companies that are increasingly being able to overcome this challenge. Lower depth of coverage, if we're using Flongo, is one of the limitations, but it may not be. So efficiency of the guides, we'll talk about this in the future directions. And then also you need really good quality DNA. One of the really good advantages to our system is when we met Dr. Kai-Yi Yeung. She's a professor in the computational science department who developed the BioDepot Workflow Builder. This is a graphical tool that has bioinformatics workflows into it. And what she did is, this is the old way of how we did this. This took over a week for us to get through a bioinformatics pipeline. And what she did was, using her BWB, she encapsulated each of these computational tasks into a Docker container. And that way we can actually, it's more reproducible and also it's faster. We can actually input our parameters in here in an online user portal. So it's much easier. And also it supports the graphical output IGB right on that cloud-based interface. And so now it's so much faster and easier to use. This is an example CML patient of how the data would come out. And in the dotted black is the breakpoint. And in the circle are your fusion reads between BCR and ABL. In the green is where your guides are cutting. And so you can see pretty clean cuts. And then down here is the PCR with patient-specific primers and the Sanger, which confirmed our finding by Nanopore. So the fusion breakpoint. And so with this system, we're actually able to confirm fusion status in a number of cell lines, as well as primary fusion samples, APL, as well as CML patients. Most cell lines, of course, perform better. We can confirm the fusion in 80 minutes, whereas most patients, we're confirming the fusion in 3 hours. And then this is a number of different ways computationally we approached it. But the key here is, instead of weeks, we're talking seconds. These are runtimes in seconds. It's just phenomenal how much faster the analysis is now. So in summary and future directions, the point of care device, it's really same day, single molecule, long range sequencing, and it works. What we need now in the future is a robust QA/QC parameters before we can clinically implement that. We have an SBIR submitted, and we're really trying to work on this in this next grant. We're testing new workflows for improved fusion detection in terms of accuracy and speed. We need to optimize the bioinformatics analysis for mobile devices and smaller devices to really deploy this into a global oncology platform. And this has a different grant pending from the Science Foundation, National Science Foundation. And can we get this thing cheaper? Flongos are $90 versus flow cells. And so that's another project that we're playing with on the side. And finally, further development of the RPA POC is, can we pair this with a blood collection device and a nucleic acid extraction device? That's also a point of care, because that would really make it true point of care. For the CLIA and digital spatial pathology labs, there's a number of things that I'm going to go through in the next 2 slides. And for GEO, we really would like more funding for the LTB support and the molecular diagnosis program. So the CLIA labs has grown, and in the future, we're probably going to be expanding this. Just 2 slides on the CODEX development and the spatial pathology data that we've been integrating into our translational research. We now have the CTP lab, the clinical trials pathology lab, the specialized pathology lab, and the immunophenotype core. The TMA services that's part of specialized pathology is paired with CLIA-governed SOPs and workflows. And so we can actually accept clinical specimens and have governance for that. We have over 150 optimized MIHC panels that are 6 to 8 plex. And we also have diagnostic clinical assays for each of our clinical trials. And including some of these are MIHC quantitative assays that are specific for our clinical trials. And our first CODEX, this is tumor microenvironment panel, has 42 antibodies. It takes about 28 hours to run a smaller tissue section and about 60 hours to run a larger. This was a Merkel cell tissue microarray with 8 regions, and this generated 1.7 terabytes of data. It took 6 hours to transfer that into another computer for analysis, and then another 12 hours just to process the data. And even post-processing, which is supposed to reduce the amount of data, you still have 700 gigabytes of data. and we're still analyzing this. This is just massive amount of data that we're dealing with. So these are some of the images for the tumor microenvironment down here. This is tumor cell markers, T cell markers, and the antigen presenting cell markers. This is just a very pretty tonsil image here. But really, how can we implement that into translational research? This is a study with the Turtle Group. Jocelyn Wright's up in the corner here, who's done a lot of this work. And we're really trying to study the prognostic and therapeutic impact of CD19 CAR T cells in treated DLBCL. This is with a 39 CODEX antibody panel targeted for lymphoma. And so these are some of the zonal patterns here, diffuse, clustered, and the zonal immune patterns here. And basically taking that into a CODEX MAV software, you can actually export that into a FlowJo style gating, where we can look at, for instance here, Ki67 positive cells that also have CD19 expression and if that varies or not. And so you can see this population does vary. And then this is another way of looking at the CODEX data. And so a lot of data that's buried into here, and we haven't even integrated this with our psych-seq data yet. So finally, I'd like to thank all of our patients and our clinical care teams for allowing this research to happen, and my colleagues at UW HemePath and SCCA Pathology for their support, all of our colleagues over at HCRI. This is my funding here, and these are the people that are involved in the work in the slides. And so I'm going to stop there.
It's always hard the way we have this set up because you can't hear the applause of the people who are watching it. That was a great presentation. Thank you. While we're waiting for other questions, I just had one question for you. With all of the advances we have, stuck out to me that you're on the committee for the next WHO Hematopathology Bible, and I'm wondering what's the next change you're lobbying for, or the next change that's going to be in that you're excited about. Is going to make the biggest difference.
I think the proper person to answer that would be Kakari Naresh. So Naresh has really spearheaded this effort and made it possible for all of us to be involved. But really, and he's an editor on the book. I've just been fortunate enough to contribute to a few chapters. But really, I think it's really exciting that the clinicians are involved and they will have a voice in what our classification systems impact the patients and how they treat clinically. I think that's probably the most exciting change.
Here we go. Here's one from David Chu. Is the data handling barrier for POCT testing outside areas with good, is data handling a barrier for point of care testing outside areas with good networks?
Yeah, so thank you for that question. That was the intent of the isothermal PCR assay, was really so that they didn't need any kind of network and they can get an answer right there in the field. And so that's the thought of having that pregnancy strip like fusion testing confirmation just right out in the field. And so that absolutely is a challenge. We were very lucky at the HCRI to have Andrea Tallerton. Literally, she went on a mission to ensure we had good connectivity and good internet. That is not the case for many of the rare areas that we are doing testing for. And that's why doing the dry blood spot cards through snail mail is one of the things that we do to confirm diagnostic CML for the MAX program and the MAX Foundation.